The initial studies we did with breast CT without contrast showed that breast CT was better than mammography for discovering masses in the breast. We then went on and we worried about calcifications and how well we were able to see them, because we weren't able to show in those earlier generations that breast CT was any better than mammography for calcifications. Well, when we did studies with contrast-enhanced CT, I realized that I don't need to look at the morphology or care about the morphology of the calcifications, because that's not even in question. Cancers as small as 2 millimeters were lighting up on the breast CT when we gave contrast to the woman, and I knew that that was a focus of cancer. My job is to pick up cancers as small as possible. As small as possible, because when we do that, that cancer is at the earliest stage, and that cancer is then the most treatable. I have seen cancers on breast CT with contrast as small as 2 millimeters. That is really, really tiny. Those are those aha moments of when you realize, wow, what I'm looking at with contrast-enhanced breast CT, I'm looking at biology. When I see something show up on breast CT, I know that I need to worry about it. And it's not something to let go. It means that this finding needs to be investigated further. Biopsy under MRI is particularly uncomfortable for a patient, because she has to lay very still after receiving the contrast until we can identify the finding and go through all of the steps that we need to go through. The problem is with MRI, we cannot approach from different angles. We're very, very limited in the way that we can approach the breast and how we can do the biopsy. And so that limits us as breast imagers in terms of what we can do. And then naturally that leads into how confident we can be about the results once we have them. Probably ultrasound is the easiest modality to biopsy a patient with. And the reason is the positioning. However, when you try to go from mammography to ultrasound, or you go from MRI to ultrasound, you have a difference in positioning of the breast. And so it becomes difficult to identify a lesion that you've seen in a modality other than ultrasound, find it under ultrasound, and then have the confidence that you are indeed biopsying the thing that you wanted to biopsy in the first place. If I see something on MRI and I worry about it, and I have to biopsy it under ultrasound, I have to find it with ultrasound in a different session. I have to do the biopsy of this finding, and I have to place a clip, and then I have to bring the patient back to MRI to be sure that indeed I've biopsied the correct thing. My hope is that with breast CT, we will have a one-stop shop of you see the finding, you know where it is, you can find it accurately at the time of biopsy, and that will simplify the procedure afterwards, where you are looking at the results from pathology and comparing to your imaging and doing that practice of evaluating, did I get the right thing or didn't I? It's going to allow us to do it with accuracy, with confidence as a clinician, so that I don't have to worry after the patient leaves my clinic if I did the right thing. And in addition to that, it will allow the patients to come in and not be afraid, not be anxious, not be in pain, and then not want to come back because they don't want to go through screening mammography. And so I hope that we have an exam here and technology that will allow patients to come in year after year, knowing that they are getting the best care that they can get.